Okay, our topic for this week is about teaching. We use this to teach client about health promotion, disease prevention, health restoration and maintenance, and rehabilitation. In general, teaching is a process of determining clients' needs and plan for specific intervention to help them learn certain or particular process or things. It is a system of activities that involves dynamic interaction between the teacher and learner intended to produce learning. Teaching is an independent nursing function and is a very important aspect of the nursing practice. It is said that the teaching process and the nursing process is alike. So let's see its comparison. In our table, we have several steps to take place. One is collect data, analyze clients' learning strength and deficits. That's for teaching process. Now let's see on the other side. In the nursing process, step 1 is collect data, analyze clients' strength and deficits. So they are alike indeed. Let's see step number 2. In the teaching process, it says make educational diagnosis. In the nursing process, it says make nursing diagnosis. So they are the same, although their focus is of different domains. Let's see number 3. In the teaching process, it says there prepare teaching plan, write learning outcomes, select content and time frame, and select teaching strategies. In the nursing process, it says plan nursing goals, desired outcomes, and select interventions. So again, they are the same. So let's see number 4. Step number 4 in the teaching process, it says implement teaching plan. Step number 4 in the nursing process also says implement nursing strategies. And number 5 in the teaching process says evaluate client learning based on achievement of learning outcomes. And in the nursing process, step number 5 also it says evaluate, but here we have to evaluate client outcomes based on achievement of goal criteria. So they are alike, but they are focused on different dimensions or disciplines. So let's talk about the recipients of our teaching. As a nurse, we teach different types of people or different groups of people. Let us see who are these. Teaching clients and their families. In here, teaching may either be one-to-one episode with a client or may involve the client's family. Particularly, this occur in a hospital situation. But teaching can occur at any situation. Like for example, a nurse can teach about wound care while changing the client's wound dressing. She may teach about the importance of hand washing to prevent the spread of infection. Or the nurse may teach about diet and exercise and lifestyle behavior that minimize the risk of heart attack for clients with cardiac problems. Teaching clients and their families includes health teachings as part of discharge plans, which are prepared to ensure safe transition of the client from one level of care to another, to include appropriate plans for follow-up education in the client's home. Discharge plans must include information about what the client has been taught before transfer or discharge, or what remains for the client to learn to perform self-care in their home. Then we have teaching in the community. Community health teachings may be aimed at small or large groups. Teaching activities may be voluntary as part of the nurse's involvement in a health organization, or teaching activities may be as part of the government's health implementation program. Teaching topics may include family planning, breastfeeding, childbirth, cessation of smoking, diet and exercise, and other topics related to community health needs. Then we have teaching health personnel. Nurses may also teach other health professionals like education of medical students or allied health students. In this capacity, the nurse educator is often clarifying the role of the nurse for other health professionals on how the nurse can assist them in their care of the client. So you learned about the recipients of our teachings. Let us see now the selected teaching strategies we can use in teaching our clients. Here we have to understand that a major type of learning consists of the cognitive, which is our intellect, affective, which is our feelings and emotions, and psychomotor, which pertains to our skills. So one is explanation or description. Like for example, the lecture that we're giving to you guys, you're listening to us and then we are discussing things in front of you. Now the focus for learning there is the cognitive, wherein we try to inculcate in your mind many things about information that you need to learn. In this strategy, the teacher controls the content and phase of the topic. The learner is passive, therefore retention is less in this strategy. So to be effective in this strategy, the teacher will initiate some questions to review the topics and let the students answer to make sure that the student understands the topic well. Next is one-to-one discussion. The focus for learning is the affective and cognitive. This type of teaching strategy encourages participation by learner and permits reinforcement and repetition at the learner's level. This strategy also permits introduction of sensitive subjects. Why? Because you tend to build or develop a bond with your client because it's one-to-one. Next is answering questions, and the focus for learning is the cognitive. Here, the students or the learners are encouraged to ask questions, and the teacher must understand the question and what it means to the learner. The teacher sometimes needs to confirm whether the question has been answered by asking the learner, "Does that answer your question?" The learner may also need to overcome cultural perception that asking question is impolite and may embarrass the teacher. Because in some culture, asking questions may be deemed as impolite. Next is teaching by demonstration. The focus of learning is the psychomotor. Demonstration is often used with explanation. Because it does not permit the use of equipment by learner, the learner in this situation is passive. But if there is a return demonstration, then there is an active participation by the learner. So retention of the knowledge learned may be for. Then we have discovery. And the focus for learning is cognitive and affective. In this strategy, the teacher guides problem-solving situation, and the learner is active participant. Therefore, retention of information is high. Then we have group discussions. The focus for learning is affective and cognitive. Have you experienced group discussions before? Where your teacher divide your class into groups and gave you a situational problem for you to solve. So in this strategy, the learner can obtain assistance from supported group, and the group members learn from one another. In this strategy, the learners are encouraged to participate and share their ideas to the group. But sometimes, in certain situation, only one person speaks for the group or only one person is discussing something, right? So in this situation, the teacher needs to keep the discussion focused and prevent monopolization by one or two learners. The next strategy is practice. And the type for learning is psychomotor. This type of strategy allows repetition and immediate feedback and permits hands-on experience. Like for example, a choreographer teaching dancing steps. The more practice you have, the more you retain the steps of the dance, because practice makes perfect. Next is printed and audiovisual materials. The focus for learning is cognitive. This teaching strategy may include books, pamphlets, films, program instructions, and computer learning. In this strategy also, the learner can proceed at their own speed. The nurse can act as resource person, need not be present during learning. The only thing is, it is potentially ineffective if reading level is too high. It means the words used in teaching or in the printing materials are very colloquial, what they say, or very deep that you cannot easily understand. So the teacher needs to select language of materials that meets the learner's needs. The next is role playing. The focus of learning is affective and cognitive. In this type of strategies, it permits expression of attitudes, values, and emotions, and can assist in development of communication skills. And because this is role-playing, the teacher must create a supportive and safe environment for the learner. Okay, so next strategy is modeling. Here, the learning focus is affective and psychomotor. In this strategy, the nurse sets example by attitude and psychomotor skills. Now, this is an example of demonstration and return demonstration. And the last one is computer-assisted learning program. And the focus of learning here are all the three types of learning: cognitive, affective, and psychomotor. In this strategy, the learner is active and the learner controls the pace. Just like what we are doing right now. You learn by computer-assisted program. So these are the selected learning strategies. You can use any of these when you teach your patients, depending on the patient's situation or condition or level of understanding. So you guys learned about teaching. Now let us understand how learning takes place. To define it, learning is a process of gaining knowledge, skills, and attitude by being taught, studying, practicing, or experiencing something. Learning is represented by a change in behavior. An important aspect of learning is the individual's desire to learn and to act on the learning, referred to as compliance. Another term used is adherence, which means a commitment or attachment to a regimen. Compliance and adherence are two words used interchangeably to describe the learner's acceptance of the need to learn and then follow through with an appropriate behavior. Compliance and adherence refers to the ability to maintain health-promoting regimens which are determined largely by a healthcare provider. Now, here are some learning theories developed to help us understand more about how learning takes place. One is behaviorism. Behaviorist theorists believe that learning should be based on the learner's behavior. They believe that an act is called a response when it can be traced to the effects of the stimulus. They closely observe responses and then manipulate the environment to bring about the intended change. So, to modify the person's attitude and response, a behaviorist would either alter the stimulus condition in the environment or change what happens after a response occurs. One behaviorist theorist introduced the importance of positive reinforcement in fostering repetition of an action. This is to increase the probability of response. For example, praising the learner or giving them some encouragement. Behaviorists like Bandura believe or claim that most learning comes from observational learning and instruction rather than from other trial and error behavior. That's why his research focused on imitation and modeling. Imitation is the process by which individuals copy or reproduce what they have observed, and modeling is a process by which a person learns by observing the behaviors of others. Then we have cognitivism. Cognitivist theorists believe that learning is largely mental or intellectual or thinking process. This theory depicts learning as a complex cognitive activity, which means that learning is largely a mental or intellectual or thinking process, just what I said. Cognitivists also emphasize the importance of social, emotional, and physical context in which learning occurs, such as teacher-learner relationship and environment. Developmental readiness and individual readiness are other key factors associated with cognitive approaches. Major cognitive theories include Jean Piaget, Lewin, Bloom. Those three are the most theories that contributed to this cognitivism theory. Piaget's work include the 5 major phases of cognitive development, which is the sensory motor, preconceptual phase, intuitive phase, concrete phase or concrete operational phase, and the formal operations phase. For Lewin, learning involves 4 different types of changes. One is change in cognitive structure, next is change in motivation, number 3 is change in one's sense of belonging to the group, and the last one is gain in voluntary muscle control. His widely known theory of change has 3 basic stages: the unfreezing, moving, and refreezing. To Bloom, 3 areas of learning have identified. These are the cognitive, affective, and psychomotor. So for Bloom, the areas for learning are the thinking domain, the feeling domain, and the skills domain. Next is the humanism theory. For humanists, learning is believed to be self-motivated, self-initiated, and self-evaluated. This theory focuses on both cognitive and affective qualities of a learner. Theories in this group include Abraham Maslow and Carl Rogers. In humanism theory, each individual is viewed as a composite of biologic, psychologic, social, cultural, and spiritual factors. Learning focuses on self-development and achieving full potential. It is best when it is relevant to the learner. They believe that autonomy and self-determination are important. The learner identifies the learning needs and takes the initiative to meet these needs. The learner is thus an active participant and takes responsibility for meeting individuals. Now, here are some factors affecting learning. Factors may facilitate or hinder learning. The nurse must be aware of these factors, particularly when available teaching time is limited. Like for example, in a hospital situation. Some patients may stay in a hospital for only about 2 or 3 days. So having these factors in our knowledge, we can make use of the appropriate time to provide health teachings to our clients. So one is motivation. Motivation to learn is the desire to learn. Motivation is generally greatest when the person recognizes the need and believes that need will be met through learning. For example, a client with heart disease may need to know the effects of smoking before they recognize the need to stop smoking. Another example is that a cardiac patient may need to know the effects of high sodium content food before they recognize the need to minimize the sodium contents in their foods. Next is readiness. Readiness to learn is a demonstration of behavior or cues that reflects the learner's motivation to learn at a specific time. For example, a client may want to learn self-care during dressing change, but if the client experiences pain or discomforts, she may not be able to learn because the pain distracts her concentration. Next is active involvement. Learning is facilitated when the learner is interested and actively involved. When the learner is actively involved, learning becomes more meaningful. When the learning is meaningful, retention is high. Next is relevance. If the knowledge or skills to be learned are personally relevant to the learner, learning takes place more easily. For example, an asthmatic patient who is at the same time a smoker, who just had exacerbation of his asthmatic attack. So this patient will more likely understand the need to stop smoking to minimize asthmatic attack. Another example is a hypertensive client who is obese, has symptoms of headache and fatigue, is more likely to understand the need to lose weight if he remembers having more energy when he is weightless. Next is feedback. Feedback has to be meaningful to the learner. Support of desired behavior through praise or positively worded corrections or suggestions of alternative methods may encourage learners to the desired goal. Next is non-judgmental support. People learn best when they feel that they are accepted and will not be judged. Next is simple to complex. If learning materials are logically organized and proceeds from simple to complex, this would enable the learner to comprehend new information, assimilate it with previous learnings, and form new understanding. Next is repetition. Repetition of key concepts of facts facilitate retention of newly learned material, and to enhance better performance of the learner, the learners need to reinforce positive feedback. Next is timing. People retain information and psychomotor skills best when the time between learning and active use of the learning is short. An example here is when you teach your client on how to do the proper dressing of wound, and you allow him to do it the next time you do the dressing. He will likely retain the information he learned previously and the psychomotor skills, like the actual doing of the dressing. But if you teach him how to do the dressing but you don't allow him to do it by himself, he may not retain the information and the psychomotor skills he just learned. Next is environment. A therapeutic environment, like in a hospital setting, can facilitate learning by reducing distraction and providing physical and psychological comfort. Privacy is also essential to some learners. Now let's discuss about barriers to learning. See, even if we use those factors that can facilitate learning, still there are some barriers that can hinder the learner to learn. So let us see what are these barriers and what can the nurses do. One is acute illness. The client requires all resources and energy to cope with illness, so he or she doesn't have the energy to concentrate in learning. So with this, as a nurse, you have to defer your teaching until the client is less ill. Next is pain. Pain decreases ability to concentrate. So as a nurse, know your patient, conduct pain assessment before teaching. Next is prognosis. Client may be preoccupied with illness and unable to concentrate on new information. So, defer teaching to a better time. Next is biorhythms. Our body is circadian in nature. So, mental and physical performances may have a circadian rhythm. So, as a nurse, you have to adapt time of teaching to suit your client. Maybe you set your time when the patient is sleepy, so he may not be able to understand what you're talking about. Next is emotion, particularly hospitalized patients, where anxiety, denial, depression, or grief is there. Emotions like this require energy and distract from learning. So, deal with the client's emotion first, and then before you can start your teaching session. Next is language. Client may not be fluent in the nurse's language. Like for example, this client came from a province and go down to the city for further management, and he doesn't understand what the nurses are talking about or what is the kind of dialect or language the nurses use. You as a nurse also doesn't understand the patient's language or dialect. So get an interpreter or other nurse with appropriate language skills. They can help you in providing health teachings to your client. Okay, next is age. For elders, their vision, hearing, and motor control may already be impaired. So when developing a teaching plan, consider sensory and motor deficits. For children, they may have shorter attention span and vocabulary differences. So you have to develop shorter teaching plan and with more active episodes. Then we have culture and religion. Some cultures or religions may have some restrictions on certain types of knowledge, like birth control information. So as a nurse, assess the client's cultural and religious needs when planning learning activities. Next is physical disability. Visual, hearing, sensory, or motor impairments may interfere with client's ability to learn. So as a nurse, you have to plan teaching activities appropriate to the learner's physical abilities. And the last one is mental disability. Impaired cognitive ability may affect the client's capacity for learning. So for this, you have to assess the client's ability for learning and plan teaching activities to complement the client's ability while planning more complex learning for the client's caregivers. So we have learned about teaching and learning. So let us see what are the areas for client education. So we have here promotion of health, prevention of illness or disease and injury, then restoration and maintenance of health, rehabilitation, and adapting to altered health and function. So for this, let's go to the part 2 of this presentation. For questions and clarifications, please direct it to your clinical instructors. Thank you.